My goal with this talk is really to take that number that Ralph talked about, those patients who present with early disease who are missed because of misinterpretation of tests or misrecognition of symptoms. And our goal should be really 100% capture rate of patients who present with clinical signs of acute Lyme disease to get treated so that we can, again, lessen the numbers of people that we're seeing in our clinics who present with chronic illness. Just as a show of hands, how many of you treat chronic illness in Lyme patients? And how many of you are treating acute or seeing acute Lyme disease in your practice? All right, so about the same amount. My disclosures is I have no financial or non-financial relationships to disclose. I'm a partner at VenMed, along with some of the amazing clinicians who are sitting here at the table with me. And we treat patients with chronic complex disease, including tick-borne infections. There's going to be a few things I talk about that may diverge from existing provincial or national guidelines, and I'm going to mark those slides just with an asterisk. Obviously, Justin has gone over why Lyme disease is important. These are just numbers from the Public Health Canada website. You can see if you follow that slope upwards, we're going to be somewhere in the astronomical range. And as Dr. Wills and Vet also mentioned, or at least in one of their studies, we're probably looking at a 10-fold or a 30-fold underestimation of the true incidence of Lyme disease in Canada. These are just some of the lovely critters that exist within Canada and that can transmit tick-borne illnesses. They all look kind of similar and are very hard to see differences, especially when they're in their nymphal or a larval stage for sure. And obviously there's other tick-borne diseases that we need to think about, babesiosis, anaplasma, Lyme disease, European strains of Lyme disease, Powassan virus, obviously relapsing fever, Borrelias, Rocky Mountain spotted fevers, and all the lovely viruses as well. And the Lone Star tick here, which we're starting to see, obviously can present with the alpha-gal syndrome. Does anyone have any patients with alpha-gal? Has anyone seen any? I'd like to start just by talking about a case report, and luckily this kid literally walked into my office 2 weeks ago, and just presented so classically. I thought this, I have to include him, and I got his parents' permission to include his case. He's an 11-year-old. He's a grade 6 student. Healthy, happy kid. Probably spends too much time on his phone, like all of our kids. And his mom and his dad are separated. Mom recently moved to a farm about 50 kilometers northeast of Toronto, just north of the Rouge Valley National Park. Again, healthy kid, but of note, kind of gets these very exaggerated response to bug bites. So, that will be important to note as we go through his history. So, end of the summer, I guess midsummer, comes in complaining of a sore neck, kind of just non-specific flu-like illness. He had a fever for 3 days and a rash, a non-specific rash on the back of his neck. 10, 12 days later, his parents note multiple bites, what they assume to be bites, all over his body, anywhere from 1 to 8 inches. And there was about 12 of them that his father noted. They rapidly kind of spread and then faded over the course of 1 or 2 weeks. His dad was really kind enough to send me pictures of the rash, or the rashes. You can see one is on his left leg, or 2 are on his left leg, one on his right arm there, and you can see just this kind of really nice central clearing with a ring around it. I think we should all look at that and think. I look at these little bites down here as those are bug bites, right? Those are just mosquito bites, but these are clearly not mosquito bites. 10 days later, this child presents to the hospital with a Bell's palsy. He was treated with steroids. He was given antivirals, and he recovered 90% of his facial nerve function within 4 or 5 days. He had an exam by an optometrist, a week later, and again, totally normal. 2 weeks later, he reports feeling unwell again. He's now got a sore neck. He's got shoulder pain. He's complaining of sporadic migratory joint pains, and He's also starting to wet the bed again, which he had not done since he was 4 or 5 years old. A month later, oh, let me lose it. A month later, almost a month later, still sick, still limping, complaining of sore pain. He's gone to summer camp. Again, not participating at summer camp, so parents take him to see the family physician. And he's peeing the bed, and so they're thinking, oh, maybe he's got diabetes, because he's a little bit of a larger kid. Urinalysis was normal. The blood work showed an elevated white blood cell count and a platelet count. And interestingly enough, his CRP was elevated as well, so thinking back to what Ralph talked about. I don't have reports for the liver function tests. So again, non-specific viral, not sure what's going on, reassured, sent home. 1 month later, now he's continuing to complain of pain in his knees and his calves. He's limping really badly for about 3 or 4 days, and all of a sudden, within about a week or so, his wrist blows up, and now he has an acute inflammatory arthritis of his right wrist. Goes to the hospital, is given some Advil, and referred to a pediatrician. At the behest of his parents, a Lyme test was performed, and luckily, it came back positive 10 days later. He was started on antibiotics. So this is mid-October. If we go back, we can see that his illness started in June. When he was bit, we don't know. I'd like to talk just about a little bit around the presentation of early Lyme disease. As you can see, the erythema migrans rash, present 74% of the time. There is a lot of conflicting literature that says it may be presenting 20% of the time, so 1 in 5 cases, up to 90% of the time. So that variation really makes a difference in terms of diagnosing it. Arthritis, obviously, in about 1/3 of patients. Other neurological manifestations. Bell's palsy will come up in about 8% of patients, and the multiple erythema migrans rash in about 6%. As you can see in this child, he had both Bell's palsy and the erythema migrans rash. This was a study that looked at children, again, presenting with an acute facial nerve palsy in a Lyme endemic region. About 30% of them tested positive for Borrelia. And so their conclusion was, again, in an area that's endemic with Lyme disease, really, if a kid comes in with a facial nerve palsy, you should presume that it is Lyme disease first and foremost. I spoke to a colleague who works in upstate New York, and this is their practice. If a kid comes in with, or any person comes in with a Bell's palsy in a, regardless of time of year, but certainly in the summertime, they get put on doxycycline. They're not given steroids or antivirals, and obviously testing is ordered. So this is a Canadian study as well. Again, that about 25% of all Bell's palsy cases are due to Lyme borreliosis, and this is a big change in practice. I spent almost 20 years in the emergency room, and certainly my practice at that time was Bell's palsy, antivirals, maybe a steroid if you believed it. So really, again, in Lyme disease endemic regions of Canada, and we've identified all of those regions here in terms of the high-risk regions. We should be treating these people who have for Lyme disease. We should not be delaying treatment while we wait for serological testing to come back. So I'll talk a little bit about the stages of Lyme disease, and just to note that these stages can overlap, that some patients may present, like many of our patients, in the later stages of disease, which with never having gone through the early stages. Early localized disease we've talked about as this localized erythema migrans rash, which is usually accompanied with that sort of non-specific, I've been infected with something symptoms. Lethargy, neck stiffness, myalgias, arthralgias, maybe some regional lymph nodes. The erythema migrans rash, I don't know how well they show up. Again, don't all look like this beautiful picture in the lower right-hand corner. In darker skin, they may appear like a non-specific dermatitis. They can look like maybe a herpes simplex rash. They may just look like a, again, allergic bug bite. There's a lot of variation in the published literature in terms of the EM rash, as I've talked about, anywhere from 20 to 80%. They can be subtle, they can go unnoticed, and especially if they're in an area where patients are not looking or doctors are not looking. And again, this is really important in terms of examining our patients. So much of our assessment these days happens online, where you get a picture of the person's head. So it's really important, I think, to see your patients in person, examine them, look under their shirts and their pants. Again, we need to be doing careful physical exams as well as really good history taking. Of note, a lot of people will get a hypersensitivity rash to tick saliva, which looks like a mosquito bite. Again, these are usually showing up early in the disease, so early the first few days after a bite. It doesn't expand. It doesn't usually get above 5 centimeters. It doesn't mean they haven't been bit by a tick. It just means that, again, it's probably not the EM rash that your patients are panicking and sending you pictures of at 10 o'clock on a Saturday night when they come back from the woods. This is a really interesting study they did that looked at how hard it is to diagnose erythema migrans rashes properly. They had a dermatologist and a family physician who was in a Lyme endemic area both look at pictures and say, how often did they agree? Only 2 of the lesions of the 70 participants were observed with a classic bullseye, kind of that ring within a ring pattern. And we had about a 50% agreement rate between 2 clinicians who, again, were experienced in diagnosing early Lyme disease. About 16% of them were thought not to be erythema migrans rashes, but other diagnoses, so ringworm, allergic contact dermatitis, and mosquito bites. And about 20% overall, only 20% had positive laboratory evidence of Lyme disease. So again, in these kind of situations, the labs are not helpful and should not be relied upon to make the diagnosis. Early disseminated disease. So again, recognizing that these stages can overlap, that patients may present at this stage rather than the early localized disease stage. It can happen weeks to months after a bite and reflects really the systemic spread of Borrelia and during which any organ system can be affected. So neurologic symptoms, cardiac symptoms, lymphatic, ocular, again, pink eye. So conjunctivitis is probably happens in about 10% of patients, and then rarely some of the deeper ocular infections. And then the multiple erythema migrans rash, which our case had today. Lyme carditis, I'll spend just a few seconds talking about Lyme carditis because, again, it can be potentially deadly in the acute phase, and as we've seen today with the case study that Vet described in late stage as well. 90% of Lyme carditis involves an AV block. Symptoms of palpitations, dizziness, presyncope, or syncope should get your patient referred to the emergency room. Obviously, if they have any sort of AV block or unstable bradycardia, they should be monitored. They should be given prompt parenteral antibiotics as well. Often by identifying these people early, we can prevent the need for a permanent pacemaker to be implanted. This was a Lyme carditis score that was developed by Dr. Baranchuk and his colleagues in Kingston called the SILK score, where if a patient presents to the emergency room complaining of symptoms or coming in with any sort of AV block or unusual arrhythmia, the COSTAR mnemonic, where basically think about constitutional symptoms, outdoor activities if they're male and they have history of a tick bite, if they're young, less than 50, or have a rash. If you have an intermediate or high score, you're going to pick up 100% of Lyme carditis in their case. This is a non-validated sample. They have not done outside validation, and so they really couldn't talk about specificity. There wasn't any control group. But again, in a review of the 88 cases that have presented to emergency rooms in Kingston, they picked up 100% of the Lyme carditis. Late stage disease. I'm going to spend very little time talking about late stage disease because I think Dr. Cook is going to talk about it after me. Months to years after an initial bite, again, the arthritis tends to be very different. It can be a persistent arthritis, a mono or oligoarthritis where you're getting one or a few joints. They tend to be the bigger joints, so knees, hips, shoulders, rather than hands and feet. The neurologic symptoms also seem to be a little bit different than the acute neurologic effects in terms of a Bell's palsy, We think about mononeuritis multiplex, those subtle sensory axonal peripheral polyneuropathies, which is a mouthful to say. But it's the thing that we hear from our patients, which is, I feel like there's rain dropping on my arm one day, and then I feel like there's pins and needles on my leg the next day, and I feel like someone is washing something over the back of my scalp another day. So those kind of things that move around. The cognitive impairment, the brain fog, and again, many of us work in brain fog clinics, and subtle balance and gait issues. People are falling over, just don't feel straight, they can't drive properly, and obviously the memory impairment and non-specific headaches. The systemic symptoms, again, that a lot of us are seeing with regards to post-exertional malaise, chronic fatigue syndromes. And again, to note that a lot of these symptoms will wax and wane over time. People will have periods of time where they feel relatively normal, maybe not completely back to normal, and then their symptoms will flare up for various reasons. There is a rationale to have a high index of suspicion and to treat early. Even our colleagues at Public Health Canada believe that those who are treated earlier in disease are much less likely to go on to have chronic persistent symptoms. They tend to recover more quickly and completely. The prevalence of persistent symptoms after treatment for early Lyme disease really varies in the literature, but the rates go up the later that you start treatment. The other rationale is that we know from studies that Borrelia can disseminate early in the course of illness. So in a few experimental studies, they've seen that even without neurologic symptoms, Borrelia can get into the CSF within 12 days of a bite. So treatment. We should not rely on the appearance of an erythema migrans rash to treat patients. Think about the history, think about the risk, and really talk about all those risks that, again, we've talked about in terms of behaviors, but risk can include gardening in your backyard. Where do you live? Where do you go? Where do your pets go? Obviously, all of southern Ontario here is an endemic region. I have patients in Alberta, and I'm always surprised that patients can still get Lyme disease in Alberta. We're not finding ticks there, but they're getting them. Again, are patients taking precautions? Are they doing tick checks? I think that one of the reasons we see a lot of kids who are, again, getting ticks sent to genetics or coming in with early symptoms is because parents are looking at their kids. When their kids come in from outdoors, they're stripping them off, they're looking behind all the folds, they're opening up the butt cheeks. So I think as adults too, when we're coming in, we need to be doing proper tick checks. And again, think about those non-specific flu-like summer flus that are not happening during flu season. My treatment guidelines are based on the ILADS 2014 published guidelines, which are available easily online. Again, when Ralph talked about a reputable minority opinion, I think we can agree that ILADS is a reputable minority opinion. Those guidelines recognize that there is very little good quality evidence in this field, that the guidelines place a high value on preventing disease whenever possible. They also place a high value on reducing patients' risk of developing a persistent chronic infection. It really emphasizes patient-centered care, which I think we all believe in, with shared decision-making that is responsive to the needs, values, and expressed preferences of individual patients. Tick bite prophylaxis. All right, here's probably the most controversial thing I'm going to say. Public Health Ontario recommends a single dose of doxycycline for a high-risk bite, which means greater than 24 hours in a high-risk area and an identifiable tick. I don't know about you, but that rarely happens. These guidelines were based on studies that used the appearance of the EM rash, so the erythema migrans rash was the clinical endpoint. So we know that, again, depending on the studies, 20% of the time it's not going to be there, or 80% of the time it's not going to be there. You cannot use the appearance of an erythema migrans rash or the non-appearance of the rash as a marker of prevention of disease. And even within their study, they had one patient who presented later with seronegative disease. The other thing was this trial was only 6 weeks long. As I've talked about, some of these symptoms are going to present months and months later. Therefore, the trial wasn't designed to pick up late-stage complications of the disease. So really, that prophylaxis, that recommendation is based on such poor quality evidence that I think we could just throw it in the garbage. So what do I do? And again, here's my practice, which may differ from existing guidelines. If possible, here's my little poll to, I always call it genetics, but I guess it's just genetics. All right. I think genetics without the K, so I call it genetics. If possible, if you catch it, send it. The service is great. Again, a little plug for Justin. I think you're doing amazing work. This is just like such a valuable tool that we use with our patients. Again, whether or not when the tick comes back negative, whether or not you decide to prophylax is a different decision because, again, exposure to ticks is exposure to ticks. So the one you caught is great, but what about the other nymphs that you didn't see? So think about that as well. And again, really discuss it with your patients, the risks and benefits of antibiotic use, and weighing that risk of developing late-stage disease. There was a small study, it was done in mice, that showed that the longer you wait after the tick bite, the less effective it was. So more than 48 hours later had less effectiveness. And another mouse study showed that with a long-acting preparation of doxycycline, that you could prevent 100% of all Anaplasma and Borrelia clinical cases. Again, there's no long-acting doxycycline preparation for humans. So what do? I give doxycycline, I give it for 21 days because it covers that 19 days plus a couple just for fun. If kids are 8 years or older, I also give them doxycycline. If kids are less than 8, again, talk to parents. It's a small, it's a very short course. We're talking about 3 weeks. They may choose to use doxycycline, but if not, you can use amoxicillin or cefuroxime. Treatment of early localized disease. My practice is that antibiotics should be employed for at least 4 to 6 weeks. Again, with similar choices of antibiotics. If you're using azithromycin, consider giving it for at least 21 days. You can see the pediatric dosing here as well. Think about using higher daily doses for adolescents, again, because they are just kind of in between those small humans and regular humans. Treatments of early disseminated disease are very similar to early localized disease with caveats that if a patient presents with neurologic symptoms, whether it's peripheral nervous systems, again, like a facial nerve palsy, or certainly any central nervous system symptoms, they should be getting doxycycline due to penetration into the CNS, or strongly consider using parenteral antibiotics, either IV ceftriaxone. Again, for a lot of us who are outside the hospital systems, getting that arranged is very difficult. My practice is to be using penicillin, intramuscular penicillin injections, again, with various doses depending on patient preference and symptoms. And obviously, patients with cardiac symptoms, we should be sending them to the emergency room. They need to be put on telemetry until they're stabilized and given IV antibiotics. Supportive therapy. So what else do? I'm going to put a patient on 4 weeks, 6 weeks longer of antibiotics. We want to support them. My practice has been to give probiotics. And I asked the question, do probiotics actually help? So there was a recent Cochrane review that looked at if probiotics are effective at reducing C. diff infections or even antibiotic adverse events. And interestingly enough, there was a 50% relative reduction, but a very small absolute risk reduction in C. diff infections with antibiotics. And again, just I think goes to speak to the very low rate that we're seeing these C. diff due to antibiotic use. The number needed to treat was about 65 patients. So again, in something that has very low risk for harm, pretty easy to make a decision to treat. So I will use probiotics in all cases of giving a patient an antibiotic. My practice is to give at least 50 billion colony-forming units daily of a combination probiotic, usually a lactobacillus and bifido, if I'm using more than one antibiotic, so a combination of drugs, I will up that and give double, at least 100 billion. I will often combine with Saccharomyces boulardii for prophylaxis of GI yeast overgrowth. We can also consider using herbal antimicrobials, and I know a lot of our naturopathic colleagues in the audience will use herbals. These are the studies that were done with Dr. Zhang out of Johns Hopkins, and I'm sure that these are hard to see, but really the point is that on the culture of Borrelia in culture, you can see that oregano, cinnamon, and clove did a really good job of inhibiting growth even at lower concentrations. We also have a lot of the other study looking at stationary phase Lyme disease that showed cryptolepsis, black walnut, Japanese knotweed, Chinese skullcap. All of those things did a very good job compared to stevia, andrographis, and grapefruit seed, which really had little or no activity against Borrelia. These are all in vitro studies, obviously, so can we actually apply them to our patients? Again, those are clinical decisions we need to make with our patients. Other things that we should talk or think about, obviously doxycycline, if we think that there's anaplasma involved. We need to consider the age, the premorbidity, the other comorbidities, pregnancy status, if patients have had steroids or not. Really, the reason I've highlighted it twice here on this slide is that ongoing assessments are really, this is what we need to do. We need to continually see our patients. We need to reevaluate how they're doing with treatment. Are they responding? Are they not responding? And really just reassessing them on every time that you're completing any form of therapy and decide what needs to happen and whether we continue treatment or not. I think I caught up.